Another Puscast, a review of the infectious disease literature, covering the first 2 weeks of April in the year 2019. Articles I find interesting or applicable to the practice of infectious diseases. References are at edgydoc.com, home of my multimedia empire of books and blogs and podcasts and apps and lions and tigers and bears, oh my. Let's move on to the literature, shall we? Oh, by the way, go Blazers. Occasionally there are these horrible reports in the news of young people who die very quickly of overwhelming infection. There was one recently, 13-year-old cheerleader feeling fine in the morning and died within 48 hours of a overwhelming streptococcal infection. It is horribly remarkable how rapidly infections can kill patients out of the blue. This was actually reviewed in a study in open form infectious diseases where they looked retrospectively at all community-based unexpected infectious deaths in Ontario, Canada over a 1-year period. And of 7,506 unexpected deaths, there were 418 that were due to infectious diseases. It was generally pneumonia followed by bacteremia from no obvious source. And the most common organisms were Staph aureus, Strep pneumoniae, Streptococcus pyogenes, and then the Enterobacteriaceae, Klebsiella, and E. coli. And the vast majority of these people got sick and died within a day. I cannot think of a way you could prevent one of these overwhelming deaths, with, I suppose, the exception of Streptococcus pneumoniae, for which there is a vaccine. But I always bear in mind that we are actually dancing at the edge of the precipice at all times, and it's amazing the number of things that can push us over the edge. One of the changes I have seen over my practice in empiricism is that when patients come in with meningitis, they are always put on acyclovir in addition to antibacterials. The vast majority of time, clinically, they don't need the acyclovir. But I suppose one of the lost arts is differentiating between meningitis and encephalitis. Antibiotics are, of course, not harmless, and in a recent study, they went back and looked to see what was associated with nephrotoxicity and acyclovir use. Amazingly, 21% of patients develop nephrotoxicity, which was amazing. Interestingly, it was not the dosage of acyclovir nor the fluid status, but the two features that were most associated with acyclovir-induced nephrotoxicity were vancomycin use, no surprise there, but obesity as well, with an odds ratio of 3.2. And it's not because the obese patients got more acyclovir. Why being obese was a risk for acyclovir nephrotoxicity was not really discussed in the article, and I can't come up with a good idea. The old saying is that it is the dose that makes the poison. As you are probably well aware, vancomycin plus Zosyn increases risk of nephrotoxicity, but generally speaking, this is in patients who are on long courses of both antibiotics. This study looked back retrospectively at patients who received short courses of the combination, more than 24 hours but less than 72 hours of Zosyn and vancomycin, and found no increased risk of nephrotoxicity. So if you're going to use the Diceribit combination antibiotic of choice in this decade, just do it for a brief period of time. And finally, an article entitled "Renal Dosing of Antibiotics, Are We Jumping the Gun?" And what they pointed out in this article is that many patients come in with renal insufficiency, but in almost 60% of cases, the acute renal insufficiency will resolve in the next 48 hours. So when someone comes in septic and you dose their antibiotics for renal insufficiency, perhaps you should wait a day or 3 to make sure their acute renal insufficiency doesn't resolve and you're not, in fact, underdosing the antibiotics. I think the take home is that for the first 24 to 48 hours after someone's admitted with an infection, you should dose their antibiotics for their pre-hospitalization creatinine, not for the one they present with in the emergency room. We always have a shortage of organs for transplant, not to play old Doors songs. And it turns out that you can give patients organs, hearts and lungs, from hepatitis C viremic patients as long as they get a 4-week course of anti-hepatitis C therapy. Those who got their organs from hepatitis C viremic patients who got 4 weeks of therapy did not go on to get hepatitis C, opening a door for another set of patients to be organ donors. Again, the benefits of the flu vaccine. This study looked at the efficacy of the flu vaccine in pregnancy and found an overall efficacy of preventing laboratory-confirmed influenza of about 40%, which is nice because influenza is associated with increased loss of pregnancy and perhaps having stupider children. There is an old study that showed that kids born during influenza season tended to have a lower overall lifetime earning potential, which I suppose you could say is a surrogate for intelligence, or not. I realize that's quite a stretch, but I think it's more compelling to say influenza during pregnancy might lead to stupider children, or at least poorer children. And a meta-analysis and systematic review of 82,354 patients with heart failure shows that getting the influenza vaccine is associated with a decrease in all-cause mortality, more prominent in the flu season, but an effect still there outside of the flu season. An article on norovirus suggests that you have more severe outbreaks with a specific strain, the G2.4 strain, and those that occur in the healthcare setting are more likely to have severe disease. It's interesting reading the article for two reasons. One, these reports are reported to the Khaleesi net, which is very Game of Thrones. I wonder if they speak Dothraki on the Khaleesi net. One of these days I'm actually going to have to watch Game of Thrones. I've read all the books. I just have never gotten around to watching the shows. I have yet to be able to finish The Sopranos, and my youngest son is still irritated at me because we never finished watching Lost together. My multimedia empire pretty much keeps me away from the television except for the Blazers. Go Blazers. And the other thing that was interesting is that, quote, outbreaks in healthcare settings were associated with higher hospitalization. Well, duh, they're in the hospital. I know, it also includes nursing homes, but I just thought that was sort of a goofy-ass sentence. Hospital-acquired outbreaks are associated with hospitalization. The Department of Redundancy Department, brought to you by KhaleesiNet. And norovirus really is a terror. I think I've been involved with 5 outbreaks, maybe 6 outbreaks at various institutions that I practice at. Hospital-acquired norovirus is awful for patients and staff, although I don't think we've ever had a death from any of our outbreaks. We've certainly had a lot of vomiting. Living in the Great Pacific Northwest, I don't have to worry much about anaplasmosis, but this article out of France looked into the best way to diagnose this disease, and they found that the PCR was the best test, but it missed some. And if you really want to make the diagnosis, you need to combine both the PCR and acute and convalescent serology. A whopping 4 out of 19 had a positive blood smear for anaplasmosis, so that is not a very good test. Whereas 14 of 19 had a positive PCR and 16 of 19 had a positive serology. I don't think I've ever seen a case of anaplasmosis here in the Great Pacific Northwest. And with the number of years ahead of me in practice dwindling rapidly, I may go my entire career not seeing one. I did not know that there was a specific form of brucellosis called a hepatic brucelloma. And there's a case report in Emerging Infectious Diseases. Quote, hepatic brucelloma is a chronic form of brucellosis arising up to 40 years after initial infection. Only 60 cases have been reported in the English language literature since 1904. HB is associated with nonspecific systemic clinical symptoms, fever, malaise, weight loss, upper abdominal pain, moderate biologic abnormalities, and typical hypodense hepatic lesion with peripheral enhancement and central calcification. I will probably never see that either, but it's nice to know it exists. And you also know the rule in medicine, though. As soon as you read about something you've never heard of before, you tend to see a case within the next week. So maybe I'll see one next week. And another curiosity, I love these curiosities, there were 5 tularemia cases in Arizona over a 2-year period. They were all due to the same Francisella tularensis group A2. And in looking at the organisms, they were all genetically identical. One would expect tularemia in different parts of the state to be genetically distinct, having evolved, as it were, separately from others. And so I like the conclusion. Quote, genetically similar isolates were found across large spatial and temporal distances, suggesting that group A2 strains were dispersed across long distances by the wind. And this has also been suggested for type B Francisella tularensis. So this may be the Bob Dylan disease. The answer, my friend, is blowing in the wind. Although one would wonder about birds as a potential vector, it's not mentioned in this article. And there are articles to suggest that Francisella tularensis can be spread by birds. But I still kind of like the gone with the wind hypothesis for the spread of Francisella. The take home, of course, when traveling to Arizona, don't inhale. Time to butcher some bacteria names. There's Burghiella zoohelcum, which is a cause of endocarditis, probably associated with dog bites. There's been a variety of bacteremias and invasive disease with this organism, and usually it is animal bites or animal exposures that is the source. Now there's a case report, or 3, of Burghiella cardium, which causes endocarditis, both native and prosthetic valve, that, at least from this article, seems to be from human flora rather than dog or cat. So there are now 2 Burghiellas that can cause diseases in humans. Zoohelcum, a zoonosis, and cardium, probably from human mouths. I used to say that I needed to know, 1,200, 1,500 different organisms, or at least recognize them to do my job. I don't think that number is anywhere near close to reality anymore, thanks to techniques that are allowing people to both grow and identify all sorts of pathogens in human beings that were unimaginable back when I was a youngster. So, how best to treat MRSA bacteremias? There are 2 publications of note this last 2 weeks. Now, for a long time, it's been noted that adding a beta-lactam to vancomycin improves outcomes in patients with MRSA. And there's several both clinical retrospective and in vitro studies to suggest that combination therapy with a beta-lactam plus vancomycin leads to better outcomes. Well, there was a study that actually looked at this in a prospective way and found that that wasn't the case, and that patients, at least studied retrospectively, actually had worser outcomes with combination therapy. Now note, this is not anti-MRSA beta-lactams, but the cefazolin nafcillin approach. And the combination group had higher mortality rates. I don't know quite what to make of this, in that most of the data points to benefit. Now we have one study that has the advantage of being prospective, does not, and finds combination therapy to be in fact worse for the patient's outcome. And unfortunately, in medicine, there's Newton's second law, that for every study there's an equal and opposite study. The other problem with this is it hasn't been published yet, so I can't read it in detail. I got this by way of the second best infectious disease blog out there, HIV and ID Observations by Dr. Paul Sachs over at the New England Journal of Medicine. The best ID blog, of course, is mine. We know that. And you can find the slides from that presentation on Erin McCreary's Twitter feed. So that's not my favorite source for the medical literature, but given the vagaries of MRSA infections, I thought I would at least mention it. More importantly, because I think combination therapy is the way to go with MRSA infections that are serious, is a study that looked at monotherapy for MRSA versus daptomycin plus ceftaroline, an anti-MRSA beta-lactam. And again, there is data to suggest that you get better killing of MRSA with daptomycin plus a beta-lactam for a variety of reasons. The monotherapy was either daptomycin or vancomycin. And the combination therapy won out with 0 mortality versus 26% in the monotherapy study, leading them to bring the study to a premature close. 0 versus 1 in 4 is pretty compelling mortality difference. I'm always looking for a reason not to give vancomycin. I really haven't been looking for a reason to give combination therapy, but daptomycin and ceftaroline really looks like the way to go on the basis of this study, especially if patients are sicker than stink. How do you treat septic native joints? Well, I was taught that staph and gram-negative rods got 3 weeks of IV and strep got 2 weeks of IV. That was based on what I was told by my betters when I was a fellow, when there was a paucity of clinical studies to guide therapeutic interventions. I think the data has become very clear, as in all infections, that less is better. This study looked at the treatment of arthritis, and patients were randomized to 2 weeks versus 4 weeks of directed therapy after surgical debridement. They all got 1 or 2 days of IV, were switched over to oral therapy, and there was no difference in outcome whether or not they got 2 weeks or 4 weeks. And this is given what I would argue would be predominantly horseshit therapy for the infections. For the Staph aureus infections, the oral therapy was augmentin, clindamycin, levofloxacin. For streptococci, patients got augmentin. Strep never makes a goddamn beta-lactamase. Why would you give augmentin? I have never understood the allure of augmentin. I suppose it was the surgeon who picked the antibiotics, because although there was an ID doc involved, I can't imagine an ID doctor making those therapeutic interventions. Clindamycin or levofloxacin. I mean, the Staph aureus should have been treated with cephalexin, assuming no allergies. The strep should have been treated with amoxicillin. So really, this is a study where they compared 2 weeks of dumbass oral antibiotics versus 4 weeks of dumbass oral antibiotics, and people did great, since it was probably debridement and IV antibiotics that cured most of the septic joints anyway. One would wonder what the outcomes would be if they actually gave optimal antibiotics, rather than half-assed antibiotics that you can get away with. Do I know how to win friends and influence people, or what? I can't find where they broke down the outcome by bug and drug. Still, it's a very compelling study, 97% cure rates with a 2-week course of oral half-assed antibiotics after a couple of days of IV antibiotics. Between this and the recent New England Journal article on treating osteoarticular infections with oral therapy, my practice has already made an abrupt change, and I'm recommending IV therapy for osteoarticular infections of all sorts much less frequently. I had a case a couple years ago of a patient with acute nephrotoxicity due to tobramycin toxicity, and it was because of the tobramycin in the antibiotic cement. That is a well-known problem, and this article had both high levels of vancomycin and tobramycin due to antibiotic-containing cement. Generally speaking, there's no standardization as to the amount of antibiotics the orthopedic surgeon mixes up in their methyl methacrylate, so it might be a good idea to double check that so you don't whack some nephrons unnecessarily. Two articles, one in CID and one in Emerging Infectious Diseases, show improved outcome in the treatment of multi-drug resistant tuberculosis by using bedaquiline, Bedaquiline. The downside of this agent has been increased mortality rates, perhaps because it increases the QT interval, an increase in mortality that was not seen in these studies. So it's in the background for potential treatment for MDR-TB. Certainly is nothing I would do by myself. I have yet to see an MDR-TB here in the Great Pacific Northwest, and if I did, I would call for help. One of the things I like to whinge about the most is no one would take care of cancer without calling an oncologist, and no one would take care of an acute MI without calling a cardiologist. But people take care of infections all the time when they have no idea what the hell they are doing, and consequently, people die. Not unsurprisingly, in a study out of Alabama, patients who got an ID consultation for candidemia had decreased mortality rates. What a surprise! Getting somebody involved who knows what the hell they are doing results in better patient outcomes. And looking at the study, 1 in 4 patients with candidemia did not get an ID consult, which implies to me that 1 in 4 physicians who had candidemia have their head up their squirrel. Where was I? Oh yeah. If you're going to have a patient with a complicated infection and you really don't know what you're doing, maybe you should give consideration to calling somebody who does. There hasn't been a study yet of complicated and severe infections from Staph aureus bacteremia to ICU infections to candidemia that doesn't demonstrate decreased length of stay, better outcomes, and decreased mortality by having someone who knows what they're doing involved with the care of the patient. Duh! This is the kind of study that gives one pause. It's a study that showed that patients who have invasive aspergillus, who also have voriconazole resistance, have a markedly increased excess mortality. The problem is when you start antifungal therapy, you don't know if you have resistant strains, and our therapeutic interventions for aspergillus are fairly narrow. And it takes a week or two to get fungal susceptibility testing back. The only thing you can say for sure is that prior azole exposure does increase the risk that your patient will have invasive aspergillus. But how do you know when you start therapy if it's the right drug or not? And if you choose wrong, even initially, mortality goes up. Start with multiple classes of antibiotics up front with concomitant toxicities and cost, and then stop antibiotics as the susceptibilities come back? As they say in the conclusion, quote, our findings underscore the need for rapid resistance tests and antifungal drugs based on new targets, unquote. The slow march of organisms northward as the environment warms. I talked earlier in this podcast about the Lyme tick walking north. Now the kissing bug, Triatoma sanguisusa, the organism that transmits Chagas disease, is now found in Delaware. Yay! It's long been known by us ID doctors that Chagas disease is present in the southern half of the United States, but now it looks to be coming north. What to do about it? You got me. Although there was an interesting report out of Iran where they put pesticide flea collars on their dogs and they had a marked decrease in leishmania in children. So maybe the solution, if you extrapolate from that, is to put dog collars around all the animals that carry Chagas disease. Yeah, right, like that's going to work. So anyway, that brings us to the end of this Puscast, a review of the medical literature that I found interesting in the last 2 weeks of April in the year 2019. References, as always, are available at EduDoc, the home of my multimedia empire. And go Blazers! As always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, take it away, Jeff.